This is Heart Rhythm TV. I'm Roderick Tung. With me today, we have Sam Asirvatham from the world famous Mayo Clinic. As everyone knows, Dr. Asirvatham is an anatomist, a clinician, an amazing teacher, a very accomplished author, but more recently has really been a leader in the field of digital health and artificial intelligence. Sam, welcome to Heart Rhythm TV.
Thanks, Ron.
So, Sam has a wonderful statement article summarizing the status of AI digital health at the Mayo Clinic with first author Dr. Lada Joby, who's an EP fellow at Mayo Clinic. And Sam, in that you kind of differentiate the differences between AI and machine learning. For novices like me, can you describe to us what the differences are, supervised, unsupervised learning?
Yeah, Rod, maybe I can uh, explain it kind of like in a Venn diagram. So, anything that's not human intelligence, so kind of like anything that's related to machines, algorithms, a generic term is artificial intelligence. So it could be as simple as a radio frequency ablation catheter system that understands the temperature, lesion formation, and just automatically titrates in some way. So, kind of the golden triad of artificial intelligence is intentionality, intelligence, and adaptability. So, something sensed in the environment and intentionality on how that reaction goes. Multiple inputs may be looked and a judgment call, intelligence made, and it can change again in the future. But when we talk about artificial intelligence today, most of the time we're talking about a subset of artificial intelligence, and that's machine learning. Machine learning is very similar to computational statistics. So, where we have data, and then from that data, it's possible to create or teach a algorithm to glean from that data the key characteristics of what we're trying to diagnose or define or identify. And one form of machine learning is deep learning, where typically neural networks, much like our own networks, are set up. So the classic example is someone just scrawls the number 9, and you have to figure out or teach an algorithm to recognize that 9. You and I will have no trouble if it's written in 5 different ways. But to teach it, it's really a picture. It's a pixelated picture. Each pixel forms the input layer of that algorithm. There's an output layer that says what's right and what's wrong. And by a repetitive process with numerous examples, it gets better and better and better at making that call, putting this information together. So closely allied term to neural networks, convolutional neural networks, where there's multiple layers, each kind of getting better with some weightage, some bias that makes it better and better and better and better at trying to identify what that is. But those are the key features in general of what we mean by artificial intelligence today in cardiology.
And one of the most fascinating and exciting projects that you have is this EAGLE study, which is a prospective randomized trial at Mayo Clinic, which is to identify LV dysfunction in a primary care setting based on an ECG. Can you tell us a little bit about more on that and what you and Dr. Noseworthy are working on?
Yeah, that's actually a great example, Rod, because the two pillars of AI in the medical field really are the ECG and natural language processing. And many folks ask, like, why is it that EP folks and cardiologists seem to have the lead in this? It's because of the unique features of the ECG. It's digital. It can be uh, judged like other pictures. It's available, and that's so important with AI since we need so much numbers to create good training algorithms. And to qualify those data, we need endpoints. So if we were to start today with some other data stream, it'll take years before we know outcomes and so on. So the ECG basis is something that our group and other groups have worked on for a while. It's quite amazing. Not only is it available, it's not just the heart, it's the autonomics, it's affected by electrolytes, temperatures, so many different things that there are already established algorithms that can help diagnose gender, age, ejection fraction, likelihood of hypertrophic cardiomyopathy, and even some promising data on predictors for sudden death. So, with all of that, and if we tackle a new problem like COVID and the key questions who's going to get sicker, who is sick, are there some specific features? It becomes an automatic go to. But the other pillar is also very important and in some ways more difficult is just natural language processing used, for example, with the electronic medical record, just lab test data that comes in, just to look again with huge training sets for predictors, prognosis, and outcomes. So the project that you mentioned really is one that does require a variety of data, multiple centers, multiple countries, different groups, rural, urban, racial differences, socioeconomic differences, and became like a idea or thought largely spearheaded by Paul Friedman and Zaki Attia to get all this together to see if we can make these predictions. Still in the learning phase, but some early features suggest that at least patient status, like how the patient is doing right now, is probably going to be the first that we can try to predict.
And Sam, as we start seeing an explosion of AI research, there's obviously common themes in which it's going to outperform humans. It's going to be able to have very good predictive accuracy, both on the negative and positive predictive side. How do people judge the quality of AI research? Is there bad AI research? Are there bad supervisors to supervise the learning? Or is it all relatively similar?
Well, the basis for AI, machine learning, deep learning, neural networks is data. So data has qualifiers. So one of the early problems recognized with AI in medicine is how were those qualifiers done? So simple thing like ECG to predict, do you have amyloidosis? So who judges whether the patient actually had amyloid or not? What's the gold standard? Like could they have been wrong? Then that training algorithm is also skewed. Are there occasional outlier type patients that have amyloid and have a biventricular pacer? And if there isn't enough of them in the training set, they're going to be misdiagnosed. So this is where unsupervised learning does have an advantage. It's kind of like an exploratory type analysis. You don't have to have the qualifiers. You just have data. You're looking and seeing what the patterns are and where the differences are to try and subpopulate or cluster individuals in different groups, which you can then subsequently look at prognosis. So, this is another way of saying this is a new physiology. This is not the hypothesis driven physiology that you and I grew up with,
Right.
but just looking at what's there and trying to find these. One of the most amazing things in my career was looking at electrograms and ECGs in maybe 15 patients who had EP procedures in multiple centers and an unsupervised network constructed by one of the leading AI people in the world today. It's incredible. Self identified not only what the P wave, QRS, T wave is, what we understand, but also found markers, for example, of atrial repolarization that you and I would have trouble trying to find. So, unsupervised learning probably is a little closer to getting away from the limitations of data and qualifiers. But another big limitations is numbers. How much do you need to get a good training algorithm? and how do you keep it self-correcting? So for these two problems, there are some exciting advances in the field of AI. One is called transform learning. So where if you have one well-constructed data set, for example, ECG looking at ejection fraction, and now you want to look at a single slice on the echo to say, can you tell right away what diastolic and systolic function are? You may not need the same numbers if you cross-train with the ECG-based algorithm there already. This is very exciting. And the most popular one of these was one developed by Google called BERT, where you could cut down the numbers you need for a training network by an order of magnitude, 10, 100, maybe even 1,000-fold decrease. And that may make it much easier. Another kind of interesting way, like if, say, we wanted to mimic how we ablate, say, a deep septal PVC, and we looked at the electrograms, we looked at the ECG, we looked at physician guidance, we looked at a mapping system. It's possible to set up an adversarial network, one looking at one stream of data and another looking at another stream of data, and they essentially fight with each other, like in game theory, but except it's not like a zero-sum game. And you can very quickly come to insights that would be tough to go with one data stream alone. And you probably know or heard, I used to play a lot of chess, international chess. And it's amazing to me what adversarial networks have done to the game. Today, the best player in the world has a rating of about 2,800, when the next best is 2,750. But using adversarial networks, using this game theory like AI, you have ratings of above 30,000. So it's just kind of blown humans by the wayside. So this is also a very interesting and exciting field that may take away some of the limitations that we have with AI today.
But can't the best chess players still beat the best machine right now?
No chance.
No
So,
chance anymore.
so just to give you the numbers, so if I played the world's best player today, give me 100 games, maybe I'll last about 30 moves. But like if the best chess player in the world plays the best algorithm in the world today, he would have to play over 30 million games just to last 40 moves. So it's just no chance. And it's not computational power. It's really the power of machine learning.
Sam, this is so fascinating, and it obviously comes to no surprise that you were a chess fanatic and expert as well. It's amazing the breadth of information that you have, and what's special is to see an electrophysiologist like you really be an ambassador to something that's much more broad within the entire field of cardiology and the evolution of AI. So we really appreciate you taking the time. I have one final question for you, which is, can we learn back from these computers, from machine learning? So let's take the Eagle study where you're going to be predicting cardiomyopathy from the ECG. As an electrophysiologist, I would guess you're going to be looking at left atrial enlargement, QRS fractionation, the QRS width, the combination of all of these, the presence of LVH, the standard things that we look at, repolarization abnormalities, to be able to predict structural heart disease. Can I then say, great, I'm not as good as the machine. It's going to identify it better than me. But how do I learn what I missed? What is that combination of what it's seeing? Or is it always going to be a black box to say we can't explain what it is, but it works better than us?
Yeah, the black box is probably the best analogy. So, we really don't know what it's seeing, but the best guesses are it's not looking at any one value. It's some kind of mixture and weightages of multiple values. Now, you and I probably do this. If we're looking at an ECG and we're trying to say, like, is this a diseased heart that we're dealing with? It's not just the QRS. You're looking in comparison with repolarization, with timing, some lead, but it's just very difficult to define. But to try to understand what's going on in the black box is another very important field in machine learning theory. So some ways to do this is to withhold data in subsequent algorithms. For example, an early algorithm in the medical field was looking at a chest x-ray to see if there's heart failure. And the algorithm was way better than any human was able to do this. So everyone wondered, what is it? Is it the curly B, curly A? What is it? So they just took away pieces of the X-ray to see where does the algorithm fall off. And to everyone's surprise, it was some part of the right atrial shadow that was the big drop off. And then after that, everyone says, oh, of course, that's where it all comes together. There's lung, there's heart, there's left sided failure, pulmonary hypertension. But nobody said that beforehand. There's another way is just like we have CT scans or MRI of the brain, there are also pictographic or virtual reality pictures of the nodes being used in the network. So you have a pattern that's kind of like a image or a CT scan of the artificial brain. And then that's used to see what's the pattern, where is the weightage mainly, what is it that can come from that. Then there's yet other ways where you try to define physiology based on outcomes. So very famous study looked at natural language processing of whole bunch of lab data to try and predict outcomes of a particular malignancy. And it turned out that the big nodal point was low uric acid levels. Nobody is going to figure that out. But then everybody gets into it and says why, and says this might be related to DNA breakdown, improvement, and you figure out a physiology that fits the facts. But the real message is it's probably complementary intelligence. Some parts we learn back from. There are some parts I think we just need to accept. Think of the analogy in theoretical physics. The atom is now just a probability function, and with electrons being some kind of likelihood. Nobody understands what that means, but we still can make great predictions and work with that.
This has been really enlightening, inspiring, and I want to congratulate you, the Mayo Clinic, and your whole group for all the accomplishments. We look forward to seeing the progress in the COVID, the ECG projects. For our viewers, this is a great opportunity to tune in to the inaugural issue of the Digital Health Innovation Summary by Ashravatham and colleagues. Thank you, Sam, for joining us on Heart Rhythm TV.
Thanks a lot. Much appreciated.